listeners, welcome to your webinar with Dr. Pascal Breton and Drs. Yuri and Dr. Ed on Tuesday, May 5th. Go ahead, doctors.
Hey, Warriors.
Hey, Warriors.
Hey, guys. Hey, we're great. It's great to have Dr. Pascal on again. So Pascal has agreed to do 4 webinars with us for an hour. So it's a great opportunity to brush up on your skill set as far as spinal reconstruction, but also obviously get some of your CE credits. But really, it's about, at this point, Ed and I, we just finished recording on Friday our first virtual tactical seminar, and we're talking about the conversion report. And one of the main points that I was trying to make is that you have to have faith, confidence, and belief in what you're doing. And without that, people aren't going to even be around to listen to the rest of the story. They need to know that first of all, you care, and second of all, that you know what you're talking about. So that's the faith, confidence, and belief. So I think that's one of the main reasons why we've got Dr. Pascal on with us today.
Yeah, Ed? Can you hear me?
Yep.
So one of the things, it was really awesome to tape the seminar on Friday. I think Yuri would agree. I was actually able to, I was a little nervous just from a standpoint of like having only 7 people in the audience versus whatever, 200-300. But we were able to get to a place where it was really an old school place. Maybe it had everything to do that we did the seminar in our practice. So there was a lot of memories and visual cues. And it's going to be really awesome. So you guys really want to look forward to this Friday, just getting back to old school, why we do what we do and how we do what we do, and how we are really the specialists. Like when you stick with spinal cord damage and spinal damage and loss of curve or reversals, there's only, when that's the focus, when that's the problem, then you become the specialist. The more we stay away from stiffness and pain and all that, everybody does that stuff. So as the profession advances, we want to remain the specialist of spinal reconstruction. And, as I was preparing over the past few weeks, and Yuri, and we had a lot of conversations, but I can tell you one of the biggest things that allowed us to go from, from 400 to 2,000 a week in just under 2 years was that we were just full out with spinal reconstruction. Like I was so excited that I actually was able to predict reconstruction in a timeline and see, and yes, as you're starting to first take your post x-rays, you're a little bit nervous, but that goes away as you start seeing the changes. But that's awesome to be able to see it. But prior to that, you got to believe it. And what really grew Hung Club to 2,000 a week, it was all about transformation. It was all about miracles and spines getting changed and nerve systems getting changed and just the miracles. And that was our number one referral base too. It was just people that get well refer people that are sick, and people that have gone through miracles that actually refer people that need a miracle. So just always remember the old school stuff, guys. It's not about new patients. It's about the miracles. It's about chiropractic. It's about the principle and being able to communicate that principle. And it's about changing people's stories. So it's really, really awesome. Looking forward to hearing the feedback from the seminar and really in this next seminar, and just really excited about actually stepping into this and engaging with what we do on a daily basis with Dr. Pascal.
Love it. I love it because you guys both brought up, actually, it's funny, both of you touched on something that I wanted to discuss today. And the first aspect, Dr. Yuri, you were saying about building that confidence and building your conviction about knowing what you're doing in your reports. And that is huge. And it was huge for me. And the research that we're going to dive into today is, geared exactly to doing that, is to building your confidence about knowing the research that's out there. And then what Dr. Ed was saying is when you get it to a certain point where you can pretty much predict the outcome. And so we're going to talk about that too. So it was a very good introduction, very timely. And so it was great. We're going to talk about that today. Cervical spine and dental research. This is, I think the fourth year now we've been going along doing this together. And so every year we try to get 4 webinars in, and we've been covering cervical spine on one, then thoracic on the other, then lumbar, then scoliosis. And that's kind of the pattern we've been taking. But this year, discussing it with doctors Ed and Yuri, we decided to really dive in and become more specialists. We're really going to focus on the cervical spine. And step one is understanding the research. And it's always about the why. Why are we doing this? And I'm really passionate about the why, about why we do this for not only our patients, but for our profession. I'm a huge proponent of building the brand equity of chiropractic and moving our profession forward. And that's going to be a lot based on the research that I'm going to be showing you guys today. So let's dive into it. So one of my biggest things is subluxation, and that's why I love working with Warriors. Is you guys are subluxation based, right? There's a huge battle in our profession. I believe even CMCC, our Canadian school, has taken this word out of their lexicon. They don't even teach subluxation to their students, their doctors. That drives me nuts, right? But the reason that this has been removed from the lexicon at CMCC is because we haven't been able to, as a group, as a profession, to build confidence in the population, the public at large, with other healthcare providers, that this exists. And to do that, we have to be able to define it, a definition. And so we've had various definitions over the years, right? They vary depending on, what camp you lie in and what technique you're using. And my personal opinion is we need a global, unified definition of what subluxation is. You think about any other condition that affects the human body, that affects human health, and we want to tell patients and tell people that subluxation is this process in the human body that will cause and lead to disease. Just like, higher blood pressure, high blood glucose, all of these problems can be defined, but then they can also be what? Measured. So not only do we have to have a good definition of subluxation to be able to communicate that effectively, we got to be able to measure it, right? And so we're going to be talking about specifically that today. We're going to talk about the established normal cervical model. So what should a cervical spine look like? What should a normal, healthy spine look like? And once we understand what normal is, and that's been proven in the research, then we can start discussing what a subluxation is. Because once your spine shifts away or deviates from the normal position, that is simply going to be your subluxation, right? Bones out of place, causing interference. So we're going to show you how to measure that. And then we're going to talk about the dental research that supports subluxation correction, supporting the adjustments and the care that you guys are giving patients in your office. So that's what the goal for today, and that's what we're going to dive into. So again, as you guys know, I follow CBP, okay? And I'm really big on CBP, not just because of the technique. The CBP, the group, is bigger than just a technique. And it's because Dr. Don Harrison, he started it talking about subluxation. So, he's someone that's producing research, validating what we do while still being true to the subluxation philosophy. And there's nobody else in our profession, no other groups that are doing this, right? And if we look here, his definition is subluxation, as seen from this discussion, is a process that involves the altered physiology of a great many soft tissue structures, both at the vertebral segment in question and other areas remote to that osseous juxtapositional loss. This subluxation process has altered the normal resiliency of the nerve tissue and thus altered its function, right? So that's the theoretical definition of a subluxation, which we've heard before in different definitions from different chiropractors, different people. What it boils down to, if we want to look at it very simply, right? What? Bone or spinal region out of place, causing mechanical stress to the spine and nerve interference. That is basically what a subluxation is, right? But to prove this exists, we got to be able to show people what out of place is. And until we establish what normal is, there cannot be an out of place. That is so crucial and so important to understand what normal is and have confidence and conviction when you're communicating in your day 2 reports or day 3 reports, doctor's reports, what that in place or what that normal is, right? So we need to establish what normal is. Then we have to show what abnormal is, aka subluxated, and then we have to prove that abnormal has consequences for the human person, leading to neurological consequences, leading to dis-ease, right? And this has to be research that's considered reliable, valid, repeatable, and obviously published in journals that have weight, that gain respect from other professionals as well. Okay, so again, CBP is more than a technique. It's biomechanics, understanding of the spine at its core level. And so that's why I'm so passionate about this technique. It's because of the fact that they're the first ones to create an operational definition of a subluxation, right? Which we're going to be able to measuring them on x-rays. And they have established that normal, the system of mechanics of the spine. So I respect them tremendously for that. Now, it doesn't mean that I'm, someone that believes that only, CBP care, doing full traction in your office and so on and so forth. I don't think that every single chiropractor has to be doing full CBP correction in their office. Not at all. I think that chiropractors can, you can adjust your patients and you can use the technique that you want to adjust your patients. And a lot of people don't want to do the traction in the office. That's the challenging part. And so the great news is now we have something called the Dental, and the Dental is a form of traction that patients can do on their own at home to continue to improve their overall spinal position, right? And that's basically exactly what I've talked about right here. The reason I don't think that everybody needs to follow CBP to a T with all of the specific adjustments and traction in the office is because of this lady's research right here. Dr. Heidi Havek's research. I hope you guys are familiar with it. Her research is amazing. I mean, she's one of the leading researchers in our profession, and the research that she's doing is showing the impact that we have on the function of the spine, on the function of the nervous system, on the frontal lobe. So very in-depth neurological research showing that we really do affect the nervous system. Okay. Now, the thing is with Heidi's research, though, it doesn't show us what's happening long-term. So long-term follow-up with patients. And so what I'm going to show you is without creating that type of reconstruction in the spine, the adjustments effect is lost over time. So that means that we're not doing the best we can for our patients if we're not also doing some spinal correction. And so things like the Dental, things like doing spinal reconstruction help improve the functionality of the spine and nervous system over time. Okay. So let's talk about this research. So if you go to this website, it's cbpnonprofit.com, you can find every single research article that has been published by this group, CBP Nonprofit. Okay, and every single year, hundreds of thousands of dollars of research donated by chiropractors are going into publishing and producing this research to be able to support what we're doing in our offices every single day, to give us, again, that clinical confidence. And they are the only group that I know of that are up to 240 research papers. That's a lot, right? 223 in print, 6 in press, and 11 currently in review. And every single year right now, we're moving up by about 25 to 40 papers, depending on the year. So, as a group, CBP Nonprofit, we're trying to put out just a plethora of information to, again, support what you do, but improve our brand equity and gain significantly more widespread credibility as chiropractors, so that we have significant research to stand on. Okay, so let's take you back to the very beginning. So Don Harrison, Dr. Deed's father, he was a chiropractor. He was adjusting people, seeing these miracles, like the miracles that it was talking about. People are getting well. This subluxation stuff, like this is real. And he went to go see his friend, Dr. Bert Holland, a statistician. He said, I want to prove to the world, I need to show people that this subluxation, this is real, and that it's causing negative health effects. And when we're adjusting these people, things are happening. People are getting well. And Dr. Bert Holland said, well, that's great, Don, but before you can show people that this subluxation exists, you have to do something nobody has done yet, and that's establish what the normal spinal position is, or what the normal spine should look like. And so that's when Don and his group started their quest to create the normal or ideal spinal model, okay? And so what they did was they chose x-rays from a clinic, 400 randomly selected x-rays, okay? But they're not just completely random. They were selected from patients that had zero health concerns, health problems, okay? So seemingly healthy people. And then when they took the x-rays, these patients could not have any signs of degenerative disc disease, DJD, any type of vertebral anomalies, okay? So they had to be healthy looking x-rays and healthy, seemingly asymptomatic patients. And so what they did was they built a mathematical model of what they believed the spine should look like. And then with these 400 x-rays, they were comparing their model or their ideal position to what these seemingly the healthiest population would be. And so their model came within a 5% error, meaning 95% confidence that their model was bang on, okay? The mean, so the average curve in the healthy population over 400 x-rays was 34 degrees, okay? So they took a bunch of different measurements and they looked at a bunch of different stuff. And then what they did is they wanted to test all of their assumptions against their model, okay? And just so you guys know, I want you to pay attention. I circled the journal up here because this is huge. This was published in the Journal of Spine. I mean, this is like an orthopedic surgical journal. So this data is very valid, reliable. And, you know, there are other healthcare professionals, like even surgeons now are using this type of information when they're making decisions about fusing spines. When someone has to get a spinal surgery, they're using the Harrison-Lordotic model because they understand that this is the best model out there for understanding the normal position of the cervical spine. The only people that still argue this for some reason are the pain-based chiropractors who don't believe in subluxation. Okay, so again, they furthered their evaluation by testing their assumptions, and what they came to was that the ideal position should be 42 degrees. So I highlighted here. The normal position in the population was 34 degrees. So again, a little bit of variance, but their model, their ideal model, was very, very accurate. Okay, so we had the starting point. We know what the normal position of the spine is like, or what the normal position of the spine should be. Okay, again, there were a bunch of measurements, but today I want to focus on these two because the majority of the general research is going to focus on these two subluxation measurements. Okay, anterior head translation and total curve. Total measurement of curve, which these are the ones that I communicate with my patients. I'm not sure exactly, you know, I'm sure it'll vary doc to doc and what you're going to communicate about, but my subluxation measurements, here are the two that I focus on because they are the two that have the largest impact on what the curve looks like, and they are the two that we can correct, I guess, the easiest on post x-ray. So anterior head translation, if you've never done this with me before, we're going to take your C7 lateral radiograph, you put a dot at the posterior inferior aspect to C7, draw your vertical axis line. So just draw a line perfectly vertical. Put a dot posterior superior aspect to C2, measure your distance. That's your anterior head translation, okay? So normal was 15 millimeters or less, and that's coming out of those 400 subjects, right? 400 subjects, they all had 15 millimeters or less. Ideal was 0. That's the ideal model. So we're trying to get our patients to this, but understanding that, you know, generally 15 millimeters or less would not be a subluxated spine. 15 millimeters or more, deviation from normal, aka subluxation, pressure to the spine with resulting nerve dysfunction. Second measurement, total magnitude of curve, so the total curve. So to measure curve, we put a line at the back of C2, right? So posterior body line, and you draw that all the way down. You put a line at the back of the C7, you draw it all the way up, and that intersecting angle should be 42 degrees. Okay, again, remember the normal in the population at large was 34. So ideally we're trying to get them to 42, but you understand that once a patient is hitting about 34 degrees, that is within normal limits. That would not be subluxated. So when we start getting less than for 34 degrees, though we start getting into 10 and 12 degrees and 15 degrees, that is a subluxated spine. Okay, now there is a variance in there, right? If you go back and you read that paper, you'll see there was a range from about 16 to 66 degrees. I won't get into that measurement now of how we decide exactly if it should be 16 or 66. That's going to be some more detailed measurements for a later clinical Q&A. But understand that the average was 34. So that's what we're targeting for in the majority of our patients. And again, if we can, you can keep pushing, trying to get to the ideal model being 42. Okay. So those are the two measurements that are really key, really important. I think everybody should be measuring because 80%, 90% of patients come into your office are going to have more than 15 millimeters, so anterior head translation and loss of curve, right? And so now that we know what a normal spine should look like, we can measure these things. We just mentioned that, okay, you can now measure these subluxations when people deviate from normal. Well, now, like Dr. Bert Holland said, is you got to do research. You have to produce research showing that when you restore the abnormal curve, you have a positive impact on the biomechanics of the spine and a positive impact on different health outcomes, right? So 53 articles now, or 53 research publications have been produced, printed on restoring the abnormal cervical curvature with, again, their resulting effects on your health. 53 papers. Again, there is nobody else in our profession and no other technique that has put the time and money into proving and supporting this like this group. So again, that's why I urge you to use these products, support them, because they are trying to produce research to support you. So let's dive into that research a little bit more. So in the early days, before the dental roll, again, a lot of the CBP chiropractors, they're doing this stuff in office. So all of these, involved methods, doing traction in the office. And so they're long visits for the patients. They don't work well in a high volume model where you're seeing a lot of people, okay? But nonetheless, we're looking at some of their first research where they were doing cervical extension traction. Okay, so that's where you're putting the head back into extension, putting some force into the neck to rehab the curve. They were getting an average of 0.33 degrees of improvement per session. In other words, 1 degree of improvement for every 3 sessions. So like Dr. Ed mentioned earlier, we can start to sort of estimate what is possible and what we can envision or expect with these patients when we start to understand this on a deeper level. Okay, so you could look at the years here where they started doing this research. Okay, so over the course of 10 years, they were able to look at about 100 different patient case results where the average improvement was 15 degrees over 45 treatments. Okay, and they were able to reduce the anterior head carriage by about 7.5 millimeters. So again, these are the 2 big measurements we're always looking at in this research. The other reason I love CBP is because they're not about 5 or 6 treatments. They create lengthy care plans, explaining to people that this is a process to create rehabilitation on a long-term scale, okay? And then one of the other key components to any good research is that long-term follow-up. Research is great when you show that you can have an impact, within that moment, that snapshot in time. But, if you really wanted to gain widespread acceptance and become the norm for taking care of patients, we have to show this very long-term follow-up, that these patients maintain these improvements and maintain the health improvements as well long-term, okay? So again, we talked about, maybe you don't want to do traction in your office, so we can do cervical extension traction with an orthotic called the dental roll. So everything here on this research page here is dental roll research. There's now 10 of them, 10 randomized clinical control trials. 3 are in review. These are the 7 that are published. And what you'll notice is, look at this. There was even a slightly better improvement per session on the cervical dental roll than there was at in-house traction. Now, I don't know exactly why that is. That's a conversation to have with Dr. Deed at some point, but this home orthotic is very effective, and it's due to the design, right? There's a very specific design. If you look down here, right, you can see the profile of the dental roll. So the curvature going up that supports the kyphosis at T2, T1, and even into C7, and then that very specific fulcrum peak that creates extension at a certain level is just extremely precise. And so because of it, this is what you can predict and expect when you choose your patients accordingly and they are compliant with the dental roll. So in other words, every 3 sessions on the dental roll, they can expect to increase their neck curve by approximately 1 degree. That's huge. So a couple other things to note about this research. It is being done by a group in a university in Cairo, Egypt. So it's not even Dr. Deed and the CBP team doing the research themselves. And that makes it even more credible because these are outside professionals that are testing CBP theory in a randomized clinical control environment where, the data cannot be manipulated or influenced by, I guess, Dr. Deed or the other CBP leaders or CBP board, if you will, right? So that is huge, okay? You're going to look at the years here. So a lot of this research is being done in the past 10 years. And what you'll notice is it's not just about pain. They're trying to test different things. They're trying to test like asymptomatic poor cervical posture, dizziness, you noticed on one of them, lumbosacral radiculopathy, So fibromyalgia. So they're trying to get out of just pain. They're trying to do papers and research projects that look at different health outcomes and also looking at nervous system function. So the fibromyalgia, that's awesome, right? It's looking at more than just pain. Lumbosacral radiculopathy, all they did here was improve neck curve, and they saw an improvement in sciatic pain, right? And so if you look, again, what are we measuring? Lordosis, anterior head reduction. Number of treatments were the same every single time, okay? Always 3 times a week, so just 2.5 months of care if you come into this column here. And then you're gonna see all the other stuff that was measured. So you have your 2 subluxation measurements here, right? And then you have your other health outcomes here. Let's circle those for you. And then you have your follow-ups, and you'll see that some are longer than others, right? They're trying, and they're going to keep following these up as much as possible. The goal is to get every single one of these to 2 years. And so this is a very brilliant design, and the design is repeated the same every single time. So you have 2 groups, okay? You have 2 groups. Approximately 20 subjects per group. And both groups are going to get what's called their manual treatments, right? Don't shoot me, I'm just the messenger. Remember, these are not necessarily always chiropractors doing this and leading this, and so they might use the word treatment or whatever else. The reality is they're doing some sort of manual. It's not really an adjustment because they're not always chiropractors. They're doing some form of manual therapy with the patients, okay? Some of them are adjustments, some are just, some stretches and tens and so on and so forth. But both groups get the exact same type of manual treatment at every single session, okay? The difference is the control group gets nothing added. The experimental group got a Denerol added. So after every single manual session, whatever they got, the experimental group would lie on a Denerol that was sized for them, okay? And then the 2 subluxation measurements, again, that they were looking for in both groups were a reduction in the anterior head translation after lying on the Denerol, and they were looking for an improvement in the curve after lying on the Denerol. So here are some of the things that you would see after in these patients, okay? I'll go through the results a little bit more in detail, but here's how they chose their patients. So there was definitely some exclusion criteria, right? Things like fractures and other health complications and diabetes and so on and so forth. So you have to exclude a bunch of people, but then you have to have specific inclusion criteria. In other words, knowing how to select your patients for the cervical Denerol. And the 2 main inclusion criteria are forward head translation. So you can see it, the distance between the green and red line, and that has to be less than 50 millimeters, right? Because above 50 millimeters, if you remember from previous webinars, you have a thoracic kyphosis problem, okay? So you need anterior head translation of less than 50 millimeters and a loss or a reduction of the cervical curve, which you can clearly see in this case. So when you choose those patients appropriately, 6 months later, you can have beautiful curves like this that improve by 20, 30 degrees with continued use of the Denerol. So this is the same patient 6 months later. All I did with this patient was adjust and cervical Denerol at home. That's it. Here's her follow-up x-ray 6 months later. Same thing. One more example of, again, choosing these patients appropriately. Less than 50 millimeters of anterior head translation, loss of the cervical curve, right? We see a straightened cervical curve here. This patient got adjustments, cervical Denerol, 36 sessions, post x-ray, 20-degree improvement in his neck curve, and a 14-millimeter reduction in that anterior head translation. So those are the kinds of things that they were seeing over and over and over with these patients, okay? So you can see the average lordosis increase in all of those papers, averaged approximately 11 degrees over 30 sessions. The average improvement in anterior head translation was 14.9 millimeters. Now, here's a point that I want to make that is crystal clear, okay? So if you're not fully paying attention, whatever you're doing, stop and listen in, because this is what's going to give you your conviction in your report of findings. Both groups, okay, they always did a follow-up exam at 2.5 months or at 3 months, right? Right when the quote-unquote treatment or research was done, both groups, they would do a re-exam. At the 2.5 month mark, both groups had equal results in every single one of these outcome measures, meaning there was no short-term benefit to having someone on the Denerol, right? All of these things could improve with some manual adjustment or putting an input into the spine, functional improvements. But what was quite interesting was that over the long term, the longer they went out, the closer they got to the 2-year mark, the more that the control group would regress back to baseline, meaning the group that did not have any structural correction regressed back to their original levels of pain, discomfort, lowered quality of life. The dental roll group maintained correction, if not even sometimes got better without any further care. So after 3 months, they stopped care. 2 years later, some of these patients were still improved results in terms of headaches, in terms of disability, so on and so forth, 2 years post care. I mean, that is absolutely amazing. That is staggering. And if that doesn't excite you to correct cervical spines, I don't know what will, right? And so that's where, when I talked about Heidi's research saying there's a functional benefit when you're adjusting these patients, you're improving them, and you're making a significant difference in impact on them. But once you start reducing them to a maintenance frequency, it becomes so important to have them doing this type of stuff at home, because you don't want them to regress back to baseline. And the only way we're going to prevent them from regressing is by having them do some sort of corrective care at home. So here are some of the most recent papers that I want to show you. So this is, again, the CBP nonprofit page. I blocked out the ones that weren't cervical dental roll randomized clinical control trials, but there's a few here that are in review. And what's really exciting about them is they're looking at what central conduction time neuroplastic changes after cervical lordosis rehabilitation. So AKA the stuff that Heidi's working on, but looking at that stuff with long-term follow-up in curve correction. This one here, they're looking at demonstration of the autonomic nervous system function and cervical sensory motor control after cervical lordosis rehabilitation. In other words, they're moving away from any pain research. They prove the pain research. Now it's time to get into more nervous system function and try and also find patients that are asymptomatic to prove that this is beyond just people with pain. So I love it. It excites me like crazy. Here's another study I absolutely love from Dr. Evan Katz. He did this himself. Again, this is another chiropractor wanting to improve our legacy and make an impact on our profession. He spent $40,000 out of his own pocket to do this research. Okay, and this is obviously my little view box is covering the title on this. But what I'm going to show you guys is Dr. Katz spent 40 grand and he rented an MRI angiogram machine for a day. And he brought patients in there that had loss of the cervical curve. And he laid them inside the cervical MRA machine, and then he did an angiogram of the brain. So basically looking at blood perfusion in the brain, okay? Then without taking them out, all they did was insert a cervical dental roll under the neck and leave it there for a couple of minutes for the lordosis to get back into position. And then they re-MRI'd the brain to look if there was an improvement in blood flow to the brain. Results? Pixel intensity increased by 23 to 225%. So there was anywhere from 23% improvement to a 225% improvement in blood flow to the brain by simply putting the person on a dental roll and improving their curve momentarily, right? Huge. This research was published in the Journal of Brain Circulation. So this work is being published in journals that other healthcare professionals are reading. Again, this is very groundbreaking work, and it's super exciting for our profession. And I think more of us need to follow this, be on board with this, but also support the doctors that are supporting us. And for some reason, the only people that are still arguing this stuff are the pain-based chiropractors. Dr. Katz got asked to speak at a neurology conference about his findings and the kind of work that he's doing. Right? So this stuff is exciting. It's promising. It fires me up. If that doesn't excite you to go back to practice here in the next month, I don't know what will. So that's what I had for you guys discussing the cervical research. We'll be able to open it up here in a second. I just wanted to give you guys my contact information. So again, here's the website. If you're ordering dental rolls, that's the website you go to if you have not done so before. If you have questions and you want to email me a case, please email me here, Dr. Pascal at Spinal Health Distributors. Sometimes I don't answer right away, so give me a few days. If you've never seen the dental rolls or it's the first time you're using them, you could go to the YouTube page. There's a lot of descriptive videos on how to use them properly there. And then lastly, we have a code for you guys to use. I know a lot of you guys are going to be getting back to clinic here. You guys have been hit hard with no practice or very limited practice. So we're giving you guys 15% off to be able to restock your dental rolls before getting into practice. You just have to use this code right here as you check out on the website. So WQ120, and that's good till May 20th to give you 15% off on your dental rolls as a thank you for also being with us, and again, supporting the docs who support you. So that's what I had for you guys. We can open it up.